Welcome to my today's classroom. In my today's classroom, I will be discussing about clinical approach in a case of jaundice. That is, how to diagnose the cause of jaundice. What pathology is causing jaundice? How it is reduced? That is all I will be discussing in this clinical discussion. So whenever a case of jaundice comes to a physician uh, in the OPD or in ward, then how to make a proper diagnosis. So first of all, you will have to inquire in such a way so that you reach a proper diagnosis, because jaundice is caused by liver disorders. It may be caused by hematological disorders. So from history and clinical evaluation and investigative approach, you will have to make a proper diagnosis. So whenever patient reaches you, first of all, you will have to decide whether the problem of jaundice which has occurred is acute or it is chronic. It may be a chronic jaundice of more than 15 days duration, or it may be of acute onset, that is a short duration of jaundice. Now, the acute jaundice and chronic jaundice both can be caused by hematological disorders, or it may be caused by liver disorders. In liver, there are hepatocytes, so hepatocellular dysfunction may produce jaundice. Or in biliary tract, if there is any pathology in biliary tract, it can produce jaundice. Or if there is any dysfunction of biliary tract, it can produce jaundice. So you will have to decide whether the jaundice in which is caused by liver pathology, it is because of hepatocytic pathology, or it is because of pathology inside the biliary tract. You will have to decide whether the jaundice is caused by any hematological disorder, and how to differentiate clinically from the hepatic disorder which is causing jaundice. So whenever a patient reaches you, first of all, you have to decide about duration of jaundice. What is the duration of jaundice, whether it is acute or it is chronic? Now, if there is a case of jaundice and it is of acute onset, usually the acute onset jaundice is caused by liver disorders like viral hepatitis. So first, you will rule out viral hepatitis from history. I have already discussed about viral hepatitis in my previous lectures on YouTube. Now, how to decide whether it is because of A virus, it is because of B virus, it is because of C virus, D virus, E virus, or F virus. So from history, you will have to inquire whether the patient has visited an endemic area with hepatitis A, E, F, or whether patient has acquired hepatitis because of some parenteral infusion, because of some sexual contact with hepatitis B patient or hepatitis C patient. So like this, you will come to know that which virus has caused the hepatitis. Usually, acute hepatitis caused by A, E, and F viruses. These hepatitis are of short duration. So, virus is one of the cause of viral hepatitis, of the hepatitis. Other causes of acute hepatitis are drugs, like some Ayurvedic drugs, some anesthetic agent, alcohol. Even alcohol can cause acute hepatitis. So from history, always rule out virus number one, and then rule out hepatotoxic agents like some Ayurvedic drugs, alcohol, anesthetic agent if patient has been subjected to some surgery and after anesthesia that hepatitis has developed and it has led to jaundice. So first thing, you rule out virus. Second, hepatotoxic drugs. So these are the two most common causes of acute jaundice because of liver pathology. Sometimes the viruses like viral hepatitis B and viral hepatitis C, these hepatitis can produce chronic type of hepatitis. That is, duration of jaundice will be of more than 6 months. So whenever jaundice is of more than 6 months and you are suspecting hepatitis B and C from history, then from the history if you are suspecting, then you will have to work on that line. Usually, hepatitis C is producing a mild variety of jaundice, mild grade of jaundice, which is sometimes passes off subclinically. You may not able to detect that jaundice, and you will come to know about complications after 3 decades or 4 decades. But in case of hepatitis B, jaundice is clinically detectable, and you will have to proceed on those lines of treatment. So like this, in chronic variety of hepatitis, one of the cause is virus. Then comes alcohol, one of the most notorious agent worldwide which produces chronic hepatitis. Alcoholic chronic hepatitis later on may produce cirrhosis and end stage liver failure. So it is necessary to detect whether the hepatocellular failure which is produced because of hepatitis is because of alcohol or some other agent, so that you can treat that patient properly, because treatment of each and every cause will differ. So another cause of this chronic hepatitis is alcohol. So like this, you will rule out alcohol from history. Definitely you will get history of alcoholism. So if patient is alcoholic, then if he is presenting with acute jaundice, then you will have to keep possibility of alcoholic hepatitis. Though hepatitis B and other viruses can cause jaundice even in alcoholics. So you will have to work on those lines. You will have to keep first possibility of alcoholic hepatitis of chronic variety in alcoholics. Apart from this, sometimes this hepatitis, chronic variety of hepatitis, may be caused by some connective tissue disorders. In connective tissue disorders, if it is because of connective tissue disorders, then in those cases, you will get history of connective tissue disorders in family. Because usually the connective tissue disorders, these are autoimmune disorders which are transmitted in families. You will get family history of connective tissue disorders like rheumatoid arthritis, like Hashimoto's thyroiditis. These are the connective tissue disorders. So if there is any such history of connective tissue disorders in family and you are getting history of jaundice, then you will have to keep possibility of connective tissue disorder, autoimmune disorder as one of the causes of chronic type of jaundice, chronic hepatitis. Apart from this, metabolic disorders are there. In metabolic disorders like Wilson's disease, again, in this metabolic disorder, this is a disorder of copper metabolism, in which copper is not metabolized properly and it deposits in liver, it deposits in eyes, in cornea, it deposits in brain. So this Wilson's disease, this is again, it is an inherited disorder. You may get family history of such disorder in family. So these patients will present with jaundice, which becomes chronic. It will produce chronic hepatitis, and this jaundice is associated with disturbance of higher functions. Abnormal movements are there. So if there is history of abnormal movements and there is history of disturbed higher functions, then you will have to keep possibility of Wilson's disease. Similarly, there is one more disorder, metabolic disorder, which is related to iron metabolism. So this disorder of iron metabolism is known as hemochromatosis. Hemochromatosis, this disorder is not common in India. It is more common in Western world. I have already talked in my previous lectures about hemochromatosis. So this hemochromatosis, this is a disorder of iron metabolism which may involve liver and produce chronic type of jaundice, chronic hepatitis. In these patients, there is associated involvement of pancreas, as a result of which patient develops diabetes. So this is known as bronze diabetes, because in these cases you will get darkening of the skin, tanning of the skin. The the people in the western world, in Europe, they are white colored, so their skin is tanned because of deposition of iron underneath the skin. Apart from this, if there is deposition of iron in lungs, patient will develop interstitial lung disease. If there is deposition of iron in heart, patient will develop restrictive type of cardiomyopathy. So these patients of chronic hepatitis with chronic jaundice, if they are associated with anemia, tanning of skin, diabetes, restrictive cardiomyopathy, and interstitial lung disease, patients they present with breathlessness. So if such type of evidence is there in history, that is showing that there is involvement of heart, there is involvement of lung, there is involvement of pancreas, there is involvement of skin. So this suggests that probably this jaundice is because of this metabolic disorder, hemochromatosis. So like this, one by one, you will have to rule out different causes of chronic jaundice. Apart from this, if there is long-standing congestive cardiac failure, in the long-standing congestive cardiac failure, whole of the organs on the whole of the liver is congested for a long time. So in these cases also sometimes there is chronic type of jaundice. So one of the causes is because of valvular heart disease, because of myocardial dysfunction, dilated type of cardiomyopathy, in which the liver is congested for a long time. Again, in this case, these cases may produce chronic type of jaundice. So this was about the jaundice which was produced by hepatocytes. This was the abnormality in hepatocytes. Sometimes what happens, jaundice is caused by involvement of biliary tract. There is involvement of biliary tract. So this jaundice, which is produced because of obstruction of biliary tract, is known as obstructive type of jaundice, cholestatic jaundice, in which there is cholestasis of bile, and as a result of this cholestasis there is jaundice. In these cases, liver cells are totally normal. There is abnormality in the biliary system, bile duct. In the bile duct there is abnormality. Abnormality may be present in gallbladder, in bile duct, it may be present at the sphincters, at the ampulla of Vater. So in these disorders, in these pathologies of bile duct, patient may present with acute jaundice or they may present with chronic jaundice. Usually acute jaundice in the biliary, acute type of cholestatic jaundice, because of biliary involvement, is because of inflammation, acute inflammation of bile duct. It may be because of acute inflammation of gallbladder, or sometimes it may be because of dislodgement of calculus which is present, suppose in gallbladder, it dislodges and reaches the biliary tract and may produce obstruction for a short duration. Then it can produce this obstructive type of jaundice of acute onset. So acute onset jaundice of biliary tract origin is because of acute inflammation usually. Apart from this, in biliary tract, many a times there is dysfunction of biliary tract, which is known as biliary dyskinesia. Movements of the biliary tract, the movements of the biliary tract which propel the bile salts and bile pigments, those movements get disturbed. There is we can say that there is slight paralysis of decreased movements of the bile duct, and because of this decreased movements there is a biliary stasis and patient may present with jaundice for a short duration. This type of biliary dyskinesia is because of mental stress. It may be because of some life stress. It may be because of, in the patients of depression, in generalized anxiety disorders, there may be dysfunction of biliary tract, and this is known as biliary dyskinesia. So these patients, they present with dull aching type of pain in abdomen and with jaundice, and this jaundice usually lasts, cholestatic type of jaundice lasts for few days, or we can say few days to weeks, and it disappears by itself. It has good effect of anxiolytic drugs and antidepressant drugs. Apart from this, one condition is known as sphincter of Oddi dysfunction. In sphincter of Oddi dysfunction, again this dysfunction is related to psychiatric problems like anxiety, like depression, life stress, the function of the sphincter is disturbed, and again because of this disturbed function, jaundice is produced, and this jaundice is again of a short duration. It disappears by itself. So these are the causes of biliary tract involvement which produce jaundice, and this jaundice is of acute type. Apart from this, there are many conditions in which there is obstruction of bile duct. This obstruction of bile duct may be because of stone, that is known as cholelithiasis. If there is obstruction because of stone, in those cases, patient will present with pain, colicky pain in abdomen, in the right quadrant, right upper quadrant of abdomen, and they will develop cholestatic jaundice. The biliary colic is there. We call it biliary colic, pain in right hypochondrium in this particular region, right side. That is biliary colic. So if there is biliary colic and jaundice associated with fever, that is suggestive of cholelithiasis. That means stone in gallbladder. Sorry, in bile duct. If there is a stone in gallbladder, that is cholelithiasis. Again, in those cases, patient may develop jaundice, and this jaundice may be prolonged cholestatic variety of jaundice. Apart from this, long-standing jaundice sometimes is seen in tumors of bile duct, in tumors of gallbladder, in tumors of pancreas, which may compress the bile duct from outside in the region of duodenum and produce jaundice. Similarly, if there is any tumor in the region of ampulla of Vater in the duodenum second part, that can also produce chronic type of jaundice. So these are the various disorders which produce jaundice, chronic type of jaundice, obstructive variety of jaundice, which is known as cholestatic jaundice. Even in hepatitis, when hepatocytes are swollen, they can also cause similar type of cholestatic jaundice, which will disappear as soon the edema, the swelling of hepatocytes goes away. Then this jaundice will also disappear. So from history like this, you will come to know that whether the liver is the cause of jaundice, whether the heart is the cause of jaundice causing congestion of liver, or whether the bile duct is responsible for that jaundice. Now, sometimes what happens, patient comes with jaundice, but that jaundice is related to hematological problems, hemolytic anemias, sickle cell anemia, thalassemia. These are the conditions also in which jaundice is present. So in those cases, you will get family history of hemolytic anemia. A person is belonging to a particular region where the thalassemia and sickle cell anemia is prevalent. So from that area, a person is migrating to other area. That means it is an inherited type of disorder. So this is altogether different from that of jaundice, which is produced by the liver disorders. So by clinical investigations, you will come to know whether the jaundice is because of liver pathology, it is because of bile duct pathology, or it is because of hematological disorders. In the cases of jaundice, in the next step, you will move on to the clinical examination, physical examination of the patient. When we do physical examination of patient, nothing significant you will get in the hepatic variety of jaundice, because in these cases only you will get slight palpable liver, or if there is cirrhosis, there is total destruction of liver is shrunken, it is not palpable, liver span is decreased. That's all you will get in the clinical examination. Or if features of chronic liver disease and cirrhosis are there, then you may get features of portal hypertension. Veins are prominent over abdomen around the umbilicus. So these features plus splenomegaly in the cases of jaundice you can get in the cases of jaundice. So in clinical examination, in case of obstructive variety of jaundice, sometimes gallbladder is palpable. Now when the gallbladder is palpable and when it is not palpable, usually in pancreatic carcinomas, when carcinoma is present in the in the head of pancreas, and if it is compressing the region of duodenum where there is ampulla of Vater, where the bile duct is opening, that area gets compressed. Pressure increases backwards and gallbladder gradually enlarges because of because it is full of secretions of bile. So it is palpable. That is known as Courvoisier's sign. It is palpable, palpable gallbladder. While if gallbladder is chronically inflamed or bile duct is chronically inflamed, then in those cases it is not palpable. If suppose if you see, if there are cases of hemochromatosis which are presenting with jaundice, and in those cases skin is tanned, and when you further examine heart, you will get features of restrictive cardiomyopathy, and if you examine the lungs, you will get features of interstitial lung disease. Similarly, if there is Wilson's disease which is affecting liver, you will get neurological signs of abnormal movements and impaired higher functions. Apart from this, you may get other features of the associated disease. Now, in various connective tissue disorders, in autoimmune disorders like primary biliary cirrhosis and primary biliary hepatitis, the bile ducts are injured gradually and they are damaged gradually, and patient develops cholestatic variety of jaundice. So in these patients of primary biliary cirrhosis, you will get episodic jaundice, cholestatic jaundice. Once there is episode of cholestatic jaundice, it disappears. Again there is episode of cholestatic jaundice, it disappears, and gradually there is a chronic jaundice. This type of disorder, primary biliary cirrhosis, is usually seen in females of age group between 35 to 40 years, and then it gradually progresses and to end stage liver failure and cirrhosis and end stage liver failure. So like this, one by one, you will have to decide the different pathologies by clinical examination and history. After this, you will move on to investigations. Keeping in mind, if you are keeping in mind that it is because of, say, viral etiology, then you will work up on viral etiology. That is, you will go for viral markers for hepatitis A, that is antibodies against hepatitis A, anti-HAV. If you are suspecting E virus, anti-HEV, these are the antibodies against E virus. If you are suspecting hepatitis B, then you will have to work on viral markers of hepatitis B, that is surface antigen of virus, hepatitis B virus, antibodies against surface antigen, envelope antigen of hepatitis B virus, antibodies against envelope antigen of the B virus. If hepatitis B envelope antigen is present in the blood, this is suggestive of acute replication of virus. So like this, you will decide about B virus. If it is chronic jaundice, that is if it is of more than 6 months, and if you are suspecting hepatitis B, chronic hepatitis B, then in that case you will have to go for hepatitis B virus DNA so that you can decide about the titer. Then you will have to study for genotype of hepatitis B so that you can go in the proper way for treatment. Similarly, for hepatitis C, you will have to go for anti-HCV and HCV RNA in cases of chronic hepatitis C. So like this, you will work up on your historical basis in investigations. If you are suspecting autoimmune disorder, then in those cases you will have to go for ASA, ANA, ASMA and LKM1 antibodies. These antibodies should be studied if you think for any autoimmune disorder, and if there is any family history of an autoimmune disorder in the family. So one by one you will move on to these investigations. So with the help of this investigation, you will reach the diagnosis that how the liver hepatocytes are damaged, by which agent they are damaged, and how to then further treat them. Now, if you are suspecting, say, cholestatic jaundice, if there is cholestasis, prolonged cholestasis, then you will go for ultrasound of abdomen In ultrasound of abdomen, you have to rule out any calculus in gallbladder. You see the size of gallbladder. Usually the size of gallbladder is sometimes increased in viral hepatitis. This is due to direct effect of virus on the gallbladder and decreased movement of gallbladder because of hepatic inflammation. So gallbladder may be distended in those cases of viral hepatitis. So you will see for calculus in the gallbladder, if you are suspecting cholestatic jaundice, you study the bile duct with the help of sonography and you see that whether there is any calculus in the bile duct, that is there is any cholelithiasis or there is any tumor in the biliary tract or in the gallbladder. So this much you can see with the help of sonography of abdomen. Apart from this, if you are suspecting pancreatic carcinoma in head of pancreas, then again you can make some diagnosis with the help of sonography. Otherwise, in simple hepatitis, you will get just enlargement of liver, and in case of cirrhosis, fibrotic liver and shrunken liver is visible on sonography. So like this, you will have to do sonography of abdomen. If there is portal hypertension, the portal vein is dilated on sonography and spleen is enlarged. So these are the features in cases of chronic jaundice in sonography. After sonography, you will go for ERCP, endoscopic retrograde cholepancreatography. This is with the help of ERCP. If you are suspecting obstruction, you can demonstrate with the help of ERCP. Less invasive procedure is MRCP, that is magnetic resonance imaging of whole of the gallbladder, cystic duct, bile duct up to duodenum. So with the help of this, you can demonstrate the obstruction. But in case of ERCP, together with this, if there is any obstruction, say if suppose there is a stasis because of some tumor or some stricture at the ampulla of Vater, then in that case you can just give a nick on the sphincter and release the pressure which is going, and whole of the bile will gradually drain into the duodenum. Apart from this, if there is any stricture of bile duct, that can also produce jaundice. So in those cases, a stent is placed in that area of stricture. If there is any tumor which is producing obstruction and it cannot be removed, then in that case palliatively a stent is placed inside to decrease the jaundice, and then further surgery can be done afterwards. So ERCP and MRCP are the other investigations which are to be done in the cases of jaundice or if you are suspecting cholestasis because of obstruction. Secondly, CT scan of abdomen. If you think that there is any pancreatic pathology or there is any carcinomatous pathology in the intestine which is metastasizing to liver and producing cholestasis there, then you can clear cut make diagnosis with the help of CT scan of whole abdomen. It's metastatic, how much it is how much it has metastasized in the abdomen, that can be diagnosed with the help of CT scan. Apart from this, these investigations you will go for upper GI endoscopy. In cases of chronic jaundice because of portal hypertension, you may get evidence of esophageal varices and gastric varices with the help of endoscope. You can demonstrate it. Apart from this, you will have to do hematological investigations. In hematological investigations, you will do biochemical investigations of blood. In blood, you will study for liver function tests. In liver function test, serum bilirubin, indirect serum bilirubin and direct serum bilirubin. Indirect serum bilirubin is increased in cases of hematological disorders. That is, it is known as unconjugated hyperbilirubinemia, indirect hyperbilirubinemia. Whenever total fraction of bilirubin is more than 75%, of that unconjugated fraction is more than 75% of total, then you will say that it is indirect hyperbilirubinemia. And if direct fraction is more than 50% of total, then you will say that it is direct hyperbilirubinemia. Direct hyperbilirubinemia is because of liver pathology. It is because of biliary tract pathology. And indirect is because of hematological disorders, hemolytic anemias. So like this, you will go for serum bilirubin, then enzymes SGPT usually elevated because of liver cell injury. Then alkaline phosphatase is usually prominent in cases of obstructive jaundice. Gamma GT is more prominent in cases of alcoholic liver disease. So like this, one by one, you will investigate these cases. Thank you.